in both our understanding of this condition and the treatment of this condition. And I hope to share that with you today. I'm going to start about the understanding of this condition. So we have known, as you know, for a long time that thyroid eye disease is associated with Graves' disease, but not everybody who gets thyroid eye disease actually has an abnormal thyroid function, abnormal thyroid blood tests. The majority do, but we've always known there's about 10 or 15% who don't. Now, we know that Graves' disease, the overactive thyroid, is due to an antibody to a particular molecule on the thyroid itself called the TSH receptor. And that was debated for many years, but we're now very convinced that is the case. And so if you do a test for what we sometimes call TRAb antibodies, most hospitals now do this, it pretty confidently tells you whether somebody has Graves' disease or they don't. So you'd have thought that this same test would work for thyroid eye disease. And it does a bit, it does quite a lot, but it doesn't always work out that the TRAb test is positive in people with thyroid eye disease. So that causes a bit of confusion. It's saying, well, what is it that is the link between the eye disease and the thyroid disease? So for many years, the assumption has been that there must be something like this TSH receptor behind the eye. And it's a mistake. What's happened is you've got a response, which was a mistake anyway, to the thyroid, and that maybe the same antibodies are hitting the back of the eye. But that doesn't quite add up if actually we can't always find those antibodies in the test in everybody with the eye disease. So this has been a subject of some considerable controversy for the last 10 years. Is the target behind the eye of the immune system the same as the target in the thyroid? To add to this, there's a particularly strong group in America who said, no, it isn't. It's a completely different thing called the IGF-1 receptor. Don't worry about what that actually is, but they're saying it's a different thing. It's this thing called the IGF-1 receptor. And on that basis, they developed, or they didn't develop because it already existed, a treatment, a blocking treatment to the IGF-1 receptor, a monoclonal antibody, which was already around for the treatment of cancer, but wasn't very good for the treatment of cancer. And they said, hey, this could be quite interesting because it's hitting what they thought was the target behind the eye. Okay, and there's certainly quite strong evidence that the TSH receptor, the thyroid thing, is present on the tissues behind the eye, but at quite low levels, which contributed to all of this. So how has research over the last few years sorted this out? Well, the treatment, the not very successful treatment for cancer that I mentioned, was used in thyroid eye disease, has now been through 2 major trials. And I'm going to refer back to it again because it was astonishingly successful in thyroid eye disease. So it represents a new approach to treatment of thyroid eye disease. But then I told you it was trying to hit a different molecule, the IGF-1 receptor molecule, which I slightly poured scorn on and said isn't necessarily the right target. So how did it work if it's missing the right target? So that's one piece of information, and I will come back to those studies in a moment. Meanwhile, back in the lab, if you want to look at it that way, 2 other discoveries were happening. So the first is that people for many years have been trying to make an animal model of this disease. Now, I know not everybody feels comfortable with animal models, but one of the things that it does do is allow us to be certain how it happens, because in this case, what they were doing is trying to give a protein and see if you can create thyroid eye disease. Now, for well over 20 years, this has failed. It hasn't been successful in trying to produce thyroid eye disease. You can actually produce Graves' disease. For a long time, they couldn't even do Graves' disease, but giving this protein, after a while, they found a way of giving it actually as DNA rather than actually as a protein, and they could get mice that had the right antibody and then became overactive on their thyroid, like the Graves' disease. So then that led to the issue that, okay, but why don't they get the eye disease? Is it that mice don't have the same eyes, or it doesn't quite happen in that way? And then about 4 or 5 years ago, a group in London at King's College in London, led by Paul Banger, said, no, we've done it. We give it in a particular way and we can actually get eye disease. And everyone said, really? No one else has managed to do this. So in fact, Paul was about to retire at this point in time, but he's worked with a group in Germany who then did it again. And they absolutely did do it again. And they managed to create what looks very much like thyroid eye disease in the mice in Germany. Now, the important thing is that what they were giving was the TSH receptor. Don't know how much you've remembered from the first few minutes, but I've got two competing stories. I've got this thing called the IGF-1 receptor, let's call it IGF, whatever you want to call it, that I was saying one American group thinks is the target, and the TSH receptor, which we know is the target for the thyroid, and we were hoping is the target for the eye disease. So when they made this animal model by giving the TSH receptor, that's almost the best evidence you could ever have that is the target, or is definitely can be the target, because that's all they gave to these mice, and they developed eye disease. They had to give it in a particular way. I'm not going to go into that in detail, but it's the first time we've ever recreated the eye disease by giving one thing. Now you might say, well, who cares? Well, we do care, because if that is the target, then blocking that target will help the eyes, right? That's where the immune response is happening. So we do care what's targeted. Meanwhile, back at the ranch, the Americans are using the wrong antibody, and they're targeting this IGF-1 receptor that they think is very important. And I hinted to you that actually worked. So let's go back to the lab again. And meanwhile, the groups in the States were also looking at the interaction between the TSH receptor and the IGF-1 receptor. And they found that they talk to each other. They're very closely linked. So it's a bit like, if you get the husband, you get the wife. So if you get hold of the family, you're going to have an effect on the whole family. And that does seem to be what's happening. So that these two receptors actually talk to each other. And almost certainly what the story is that the disease is caused by you making an antibody to the TSH receptor, which then wiggles the IGF-1 receptor because they're tied together, if that makes any sense. But what then, of course, was intriguing, that an antibody to the other partner, I don't know whether that's the husband or the wife in my analogy, I'm not sure which one that is, so the IGF-1 receptor was looking very promising clinically. Just before I get into that story, which is quite important, I just want to tell you about a few other things. So we have had research over the last year or so looking at things you can use other than steroids. Many of you will be very used to the idea that the main treatment we have for thyroid eye disease that is not surgery has been steroids. And we've learned over the last 5 to 8 years that the best way to give the steroids is actually into the vein, that it has more of an effect than giving it as tablets. So that's what we've done, and it is more effective giving it that way. But you don't want to be on steroids forever. So I think most people on the call will know what the side effects of steroids are. They make you put on weight, they change your facial appearance, they increase your risk of diabetes, they thin out the bones. They're not the best drugs to be on, even though we've known them for well over 60 years. So mostly what people stop giving the steroids after typically around 12 weeks. But the eye disease is active for longer than that. So people have been looking at what other drugs you could give to kind of make the honeymoon last a bit longer, to stretch the effect out for a bit longer. And we've reported, 2 trials have been reported of 2 different drugs, mycophenolate mofetil and azathioprine. And some of you have probably been on one of those drugs at some point. And both drugs were somewhat reassuring that those drugs do keep things going after the end of the steroid treatment. So if you're on that and the steroids, it's better than being just on the steroids alone, probably because most of the effect is after the steroids have wound down, these drugs keep things going, and they're tablets. So that's another option. So that's good news that we've got like a second thing we can add in to keep the effect going for longer and get better results. And that's kind of useful to know. In one of the studies that actually we conducted, we also included radiotherapy. And we went as far as having blinded radiotherapy. So what that meant is that everybody in the study had to go and lie in the radiotherapy machine and have a noise that is the buzzer that happens with radiotherapy. But in fact, in half of the people, we didn't switch the machine on, and they never knew. And the people who were studying them didn't know. So if you like, is what you call sham radiotherapy. And you have to do things that way because often you get you feel great that somebody's doing something if you lie in an expensive machine for 10 days. But I'm really thankful to all the people who took part in the trial, because half of them did lie in the expensive machine, went every day to the radiotherapy department, and they weren't getting radiotherapy. We did reveal to them at the end what they had and hadn't got. But that said, the end of that result trial suggests that if you're already on high dose steroids, the radiotherapy probably doesn't add that much. It probably is an effective treatment on its own, but it didn't seem to add that much as an add-on to the high doses of steroid. And that could be useful to know because obviously for those of you who had radiotherapy, it's quite a prolonged procedure. It's a lot of time, a lot of effort, a lot of setting up. And it suggests maybe that's not the best thing to be going for when you're already on a lot of steroids and other drugs as well. So that leads me into, before I get to the new antibody treatment, just to mention one other thing that I think I have touched on with some of you before, which is what we call a TEDct study. So this is a study in which we're trying to do is to prevent thyroid eye disease. That seems like a good idea, doesn't it? Well, it's because so about 10 years ago, we had a meeting in Amsterdam that says we should be doing better. We should be doing better to prevent people getting bad eye disease, not just waiting until it happens. And we should all try harder. And different places around the world have tried in different directions. But as we were thinking about it in the UK, the penny began to drop that actually we know who's going to get thyroid eye disease because most of them have got Graves' disease. So isn't that a clue? If they're already going to the endocrinologist, isn't that a clue that they could be at risk of getting thyroid eye disease? So why don't you do something about it? What is it that we could do about it? Well, as we look through the literature, the research that already was there are some fairly obvious things. The most obvious is smoking. So we know in every trial that smoking increases your chance of getting eye disease. When you get it, it's worse. And when you have it, it's harder to treat if you are a smoker. Now, it's not so easy to stop smoking, but if you target people where it really matters to them, it helps with the message. So one of the plans here was to say to people who've got Graves' disease, now, look, you particularly should stop smoking because you are particularly at high risk of getting eye disease. And we created a brochure, which some of you might have contributed to, that explained particularly from people who had thyroid eye disease why stopping smoking in that particular situation was very important. The second thing that we did in this program was to say, well, we know that radioiodine can occasionally increase your risk of thyroid eye disease, and if so, you can have a short course of steroid to prevent that happening. And also, you should try and prevent people going very low hypothyroid after their radioiodine. So that was the second thing we built in to try and prevent, is to say to the endocrinologists, hang on a minute, be careful with your radioiodine when you know it's Graves' disease. Behind all of this, we said to the endocrinologists, and this might surprise you, do check that they have Graves' disease. Now, you might think that's incredibly obvious, but the antibody test I told you, the TRAB test, was not being done right around the country. And it only has to be done once, and it proves whether you've got Graves' disease, and it's pretty much 99% accurate. So again, part of this TEDct program was to get all endocrinologists to do that test, because then they can say to the patient, you actually do have Graves' disease. Not you probably do have, you definitely do have, and therefore stop smoking. We'll be careful about the radioiodine. And the third piece to this was to say, I'm going to give you a little card that says, if you develop itchy eyes or puffiness around the eyes, don't let anybody say you've got conjunctivitis. Start saying, you know what, this could be thyroid eye disease. And get in touch with your endocrinologist or with ophthalmologists promptly, because many of you may have experienced this. Many people had long delays before people realized they've got thyroid eye disease, and they said, and all sorts of things. It was considered to be allergy and this and that and the other, which delayed their getting treatment. So the simple idea of giving people a little card to have in their wallet, like you do when you're on steroids, and to say, if you develop any of these symptoms, itchiness, pain behind the eyes, swelling around the eyes, redness in the eyes, don't just ignore it, and don't let people tell you you've just got conjunctivitis. show them this card to say, look, I've got Graves' disease. It's much more likely that I've got thyroid eye disease. I need to see somebody who knows what they're talking about and get onto the treatment as quickly as possible. So all of these formed part of a program that we were rolling out through all the endocrinologists in the whole UK, through in 16 different regions at a time. We had lead people in every region. We called this the TMED5 program. It's been stalled a bit by COVID because many of the endocrinologists have been involved with dealing with COVID, but we'll be bringing it back hopefully at the end of the year so that this prevention program will carry on. So just to finish off then, I want to come back to this antibody treatment that I mentioned. So it's called teprotumumab, if you can remember that. You don't have to. And it's an antibody to the wrong protein. Remember, it's to the IGF-1 receptor, and it's the antibody that was a failed treatment for cancer, basically. But it was being made by the company, and they said, well, you know, don't know what to do with this. We've made it, don't know what to do with it. It's given by an intravenous infusion. So they tried it out, and it had remarkable effects in not only reducing the inflammation in the eyes, but for the first time, it was the first medical treatment that reduced proptosis, how forward the eyes were, by about 2 to 3 millimeters. And steroids are very good at reducing the puffiness and the swelling, but they're not very good at reducing the stariness of the eyes, the proptosis of the eyes. So that was quite remarkable. Now, when they did the study, it was a bit controversial because they did it versus what they call placebo. In other words, they didn't compare it to steroids. Normally, when you do a new drug, you have to compare it to the standard of care, what you give anyway. So some people were a bit uncomfortable about how the trial was done because it just said, well, we're not going to give you anything for the people in the control group, and we're going to give the people the treatment. Anyway, that happened, and the effects were fairly dramatic. But in order to license a drug, in other words, for a drug to be said, it says on the box, it can be used for thyroid eye disease, you need to have usually 2 trials to show that it really is effective. And so they repeated the trial again, and it had absolutely the same effects. And what was impressive is that it also improved people's quality of life. So when people filled in questionnaires to say, how do you feel about your eyes? That was also improving as well. And that's very important. It's all very well to have measurements that improve, but it's very important that the patients feel that those things have improved. So where is this drug, you're going to say to me? Why haven't I had it? When's it coming? And thereby goes a slightly sad story in the sense that it costs a lot of money. And when you market these kind of drugs, they're thinking, well, this is not a blockbuster that's going to be given to hundreds of thousands of people. It's going to be a small number of people. How do I get my money back from all of the trials that they've done? So it's available in the United States, but it is not available, as far as I know, anywhere in Europe at the moment. At the moment, the suggested price is about $33,000 for the treatment. And the struggle in the European countries and in the NHS is to say, well, can we really afford to pay for that? Is that the right thing that we ought to be doing? However, on the good side is it started everybody thinking about this. And so there are new treatments coming along, treatments actually that block the right molecule, the TSH receptor, and other treatments that interfere with antibodies that are beginning to be brought into this market to say, well, maybe this will work. So if you like, we're banking on the success of the first one to say, what about the second one? So I can't tell you when this is going to be available within the UK, and maybe there's others who can say more about that. But at least it's opened up the fact that we really understand these much better than we did 5 years ago, that we have the option of different treatments that are not steroids, that actually can maybe reduce the requirement for surgery at the end of the day, which is what you want. We've just completed, and we're still working on the analysis of it, a 3-year follow-up of the azathioprine study. And it's very interesting because most people have never followed patients all the way through to 3 years, the same people from the beginning to the end of the 3 years. But we knew slightly what we were going to find is that many people still, their eyes are not normal. You can tell me this. They're not normal 3 years later. So we do need to improve on the treatments at the beginning and on the timing of surgery to get people's eyes back to where they want them to be. So I'm going to stop there, Rebecca, and open up to questions.